Live your life within the moment. And don't go wait until the morning. You never know when it is over. All that I know is we'll get older. So let us dance this night away.
Before we begin, please listen to the following important public service announcement from the Honorable and late Judy Heumann. Judy is the former United States Assistant Secretary of Special Education and Rehabilitative Services in the Clinton administration and the former U.S. State Department Special Advisor for International Disability Rights in the Obama administration. Recently, Judy starred in the Netflix documentary Crip Camp.
Hello, my name is Judy Heumann. I'm here today to encourage you to please take your COVID vaccine. And if you have friends and family that haven't, please encourage them also. COVID is to be taken seriously. In addition to taking the vaccine, please use other protective methods. Wear a mask, use gloves, and sanitize frequently. If you need additional information and you live in Eastern Oregon, you can contact EOCIL. Thank you, and protect yourselves and the community.
Hello and welcome, everyone. My name is Richard Rojas, your host of the Sexual Health Spotlight, Navigating HIV and Wellness. Join us on the Sexual Health Spotlight as we shine a light on vital topics surrounding sexual wellness and HIV. In each episode, we delve into the complexities of sexual health, offering insights, advice, and personal stories to empower and educate our listeners. From understanding the basics of HIV transmission to discussing stigma, prevention, and treatment options, we cover a wide range of essential topics with compassion and expertise. Our conversations feature healthcare professionals, advocates, and individuals with diverse experiences, providing diverse perspectives and valuable insights into the journey towards sexual well-being. Tune in to Sexual Health Spotlight to stay informed, inspired, and engaged in the ongoing dialogue about sexual health and HIV, as we strive to create a world of understanding, acceptance, and support for all. Today, I will be speaking with Chris Fox, and our first episode is just going to be HIV 101. Chris, I'm not going to give a super lengthy introduction. I want you to be able to share all about yourself. So can you just start off sharing a bit about your background and experience in HIV medicine?
Sure. I'm a nurse practitioner. I currently work at OHSU in Portland. I do primarily HIV primary care, but I also see patients around the state for HIV consultation. So someone might live, on the coast or far away, and I will manage their HIV care. And then I'm also the leader of our teleprep program, where we use video to provide HIV prevention services to people around the state. So that's kind of what I'm doing now. In terms of my background, I was not a nurse originally. I have an undergraduate degree in English, and I worked in publishing for a few years after school. And I quickly found out that was not going to be the long-term career for me. And at the same time, I was doing some volunteer work for the GLBT National Hotline and talking to people about HIV and concerns about risk and whatnot. And I found that to be way more rewarding than my day job working in publishing. So I ended up getting a job at the San Francisco Health Department doing partner services for HIV. So helping people with new diagnoses find care and talk to their sex partners about possible HIV risk. And through that, I kind of became more exposed to the whole HIV healthcare world. And then I ended up doing a accelerated nurse practitioner program at the University of California, San Francisco. And that's kind of my educational background. I have been in Portland for almost 8 years and been practicing in the same HIV clinic during that time. Before that, I was working in San Francisco teaching. I also worked at the at a gay men's sexual health center in the Castro. So that's kind of a little bit about me.
Wonderful. I think that's such an awesome journey to go from English to now where you're at today in HIV
Mm-hmm.
care. That's awesome.
Mm-hmm.
It's something similar with me. I started in music, so I studied music in college, and then I added sociology onto there, and it just kind of grew this passion about society and the issues that we see today in society. Um,
Mm-hmm.
and learning in this position as assistant director of HIV outreach services, being able to learn so much about HIV and be in this amazing world with so many awesome peers has been great. Uh, Tell us more about like what motivated you. I know you told me a little bit about um, the jobs that you had that got you into HIV
Mm-hmm.
care. Tell me a little bit more about that.
Yeah, so I mean, I was born in the late 70s, so almost my entire life, HIV has been around. And it's been, from the early horrible days in the 80s and 90s, through now where we have all these great treatments that keep people alive and healthy. And also just as a gay man, that's HIV's always been in the picture, either as something to be afraid of or something that has touched people in my community, and that sort of thing. So I think a lot of my motivation is really to be of service to the community of people that are affected by HIV, whether it's through prevention or treatment. And HIV is a disease that historically has affected a lot of people that are living on the margins of our society. And it's really rewarding to me to show up for those people with, a lot of respect and, to honor the dignity in people's lives and to try to keep them healthy. Because a lot of folks have been sort of cast away from larger society.
Absolutely. And I think you've spoken a lot about, just your passion and what that looks like in HIV. What would you say to providers who are on the fence or are interested into going into the HIV field? I know that
Mm-hmm.
at least on the Eastern Oregon side, we lack providers that specialize in HIV care.
Mm-hmm. Yeah, I think that if you're interested in vulnerable populations, I think HIV is a great field to be in. Um, I think it's awesome that it's a field where there's a ton of innovation happening constantly. So if you're someone who enjoys like things changing a lot and kind of keeping up with that, um, I think that's a great reason to go into HIV care. And I also just think that like the community of the HIV community in terms of healthcare, HIV services, I think it's a great group of people. It's people who are extremely dedicated um, to their work and really care about their clients or patients or community members. So I think I can't imagine working in a different field.
Absolutely. I would definitely agree with you on that. I think being new to the HIV field, that passion and that care that a lot of these providers have and that I work with is right up front and it's noticeable. And I think that that's something that's
Mm-hmm.
very admirable. Going into understanding a little bit of HIV, of what HIV is, right? There's a lot of history, but there we lack a lot of new knowledge, I'd say, right? A lot of people learn about HIV maybe in their high school sexual health class, if they had one. Um,
Mm-hmm.
but for those who may not be familiar, could you provide a brief overview of what HIV is and how it affects the body today?
Sure. Yeah. So HIV it's human immunodeficiency virus. So it's a virus that will infect the body, and it unfortunately, so viruses usually use a type of cell in the body to as part of their replication process. So in order to make more copies of a virus, they need some kind of human cell. And in humans, for HIV, the cell they go into is a cell called the CD4 cell or T cell. And that is a white blood cell. It's part of our body's immune system. I kind of think of it as the general of the immune system because it is responsible for telling a lot of other parts of the immune system what to do when they see some kind of invader. But unfortunately, that is the cell that HIV uses to make more copies of itself. It basically, the HIV goes into the CD4 cells and it kind of hijacks them and turns them into a factory for HIV, and it kills those cells in the process. And so you can imagine if you're killing off this really important white blood cell in the immune system is going to get weaker and weaker and weaker over time. And then that's kind of when HIV, if it goes untreated, creates all the problems, all of the sort of disease states that we're concerned about. So people get infections, weird kind of, fungal infections or other kinds of bacterial infections that you wouldn't really get if you had a healthy immune system. People can get cancers that they would not ordinarily get if they had a healthy immune system. Their bodies can kind of waste away. They have just a lot of symptoms. And they, so unfortunately, that's kind of what the disease, that's kind of when the disease process happens. So that would be what we think of as acquired immunodeficiency syndrome, or AIDS. And unfortunately, that can be fatal if untreated. So, HIV is famous for taking someone in kind of like the prime of their life, where they're like young and healthy, and you think they're going to live forever, and then it just kind of causes them to waste away.
And could you tell me a little bit more about the timeline of an HIV contraction, right? You talked a little bit about how people can see unexpected fungal infections, cancers. What does the infection timeline look for that?
Yeah, I mean, so HIV it's actually a pretty slow moving virus. So it's not like, if you catch COVID, you're going to have a COVID illness, within a few days of catching it. But HIV, you can catch it and have it for years and not know that it's replicating in your body. And so probably the average is about 10 to 11 years from when someone is infected to when the sort of like the late stages of AIDS happen. But everyone's a little different. Everyone's immune system is different. So it can really depend on the individual. So some people might get sick very fast. Other people, I have patients who could have been living with it for like 8 to 10 years before they even had a test and found out that they were infected.
Yeah, and I mean that drives a really good point of testing is important, right? It's one of our biggest prevention tools that we'll talk about here a little later.
Yeah.
But who contracts HIV? Who is a person that is at high risk?
Yeah, well, I mean, so we think of HIV as sort of targeted at certain groups, but it's really not targeted at people. It's more targeted. It's spread through certain kinds of different types of risk or risk behaviors. So that could be it's spread through some different body fluids, so blood, semen, breast milk, and vaginal secretions. And so it can, if someone's comes into contact with one of those fluids and that's infected with HIV and gets that fluid into their system, HIV can be spread that way. So that can be through sex, probably in terms of like the riskier types of sex would be like if someone's having anal sex and bottoming, or someone's receiving vaginal sex. It can be spread through sharing injection equipment or needles. If people are injecting drugs, it can be spread from a mother to her child during pregnancy or during breastfeeding. And then if someone were to have something like a needle stick, so say someone who's a healthcare worker accidentally sticks their their hand or something with a needle that had been used with someone who has an HIV infection, HIV can be spread that way. And in the early days, HIV was also spread through blood transfusions. So, which is probably the highest risk thing you could do in
Yeah.
terms of HIV risk. So
Yeah, we see
I think
a
I
huge,
covered it all.
yeah, we see a huge case with that with Ryan White, right? That became
Mhm.
a really big story. Ryan White was, for the listeners who may not know who he was a young child who received a blood transfusion back when we didn't have all these protections with
Mhm.
blood transfusions, and contracted HIV.
Mhm.
Uh, and you mentioned a little bit of the contraction methods. Now, we know something that's called U equals U. And
Mhm.
how does U equals U, undetectable equals untransmittable, how does that fit into the spread of HIV?
Yeah, so undetectable equals untransmittable means that if someone has HIV and they're on treatment and they're stable on treatment, so they're taking their medication every day, and they have what's called a viral load less than 200 copies per milliliter, it is impossible for them to spread HIV through sex. There's absolutely zero risk. And the research has looked at like over like 140,000 different sex acts, and there have been no genetically linked transmissions of HIV when someone has an undetectable viral load. So, and just to explain what a viral load is, it's a way that we measure how much HIV is circulating in someone's body. And if someone is untreated, their viral load could be anywhere from, the hundreds to the thousands to sometimes the millions. Um, uh, and then, but treatment brings it down to where we can't detect the levels of the virus anymore.
Wow. And you
So,
said something really important there that I want to just kind of emphasize for the listeners. You said zero and impossible, right? So
yes.
I've heard low risk, I've heard many things, but I think it's important for people that are listening to hear that zero and impossible. And can you tell us why that is as opposed to low risk?
Yeah, so I think the words we use really matter, especially from the point of view of stigma. So it is, we know based on the science, multiple studies have shown that it is impossible to transmit HIV if you have an undetectable viral load, and that's transmitting it through sex. We don't know if U equals U works for breastfeeding or like needle sharing, things like that, but it certainly does decrease the risk for those as well. We just don't have the data is not as available for those types of transmission, HIV transmission risks. But yeah, I just think that I always counsel my patients, it's zero risk. I always, when I do teaching of students and other healthcare providers, and I always say, the words we use matter. We should not say like it's nearly impossible or there's virtually no risk. We really need to use the word zero because that's the fact, that's the science. And by using words like that, we're really kind of dismantling some of the stigma around HIV. One thing that a lot of people living with HIV really fear is infecting someone else, so removing that risk is hugely powerful.
Absolutely. I would definitely agree on that. Um, now that we know a little bit about contraction, we know about U equals U, why and who should get tested for HIV?
Mm-hmm. Yeah, well, so everyone should. So, so the anyone, I think it's between the ages of 15 and 64. You don't quote, well, I guess you are kind of quoting me on that, the guidelines, the national guidelines we have in the United States basically says everyone should get an HIV screening at least once during their lifetime. And for people that have kind of ongoing risk, they should be screened more frequently. So if you're someone who is in a community where there's a lot of HIV, and you're having a lot of sex, say, getting screened every 3 to 6 months is a really smart thing to do to stay on top of your status. But yeah, it should be. I think there's this idea out there that only testing is only for people that have obvious risk factors. But if we're going to end the HIV epidemic, we're not going to be able to do it just by testing people that, we think of as being most at risk for HIV. Everyone needs a test. And I do have to say that, like, unfortunately, I do see patients every so often who come to me very late in their diagnoses, and they just never got a test because they thought they were low risk. They didn't know that they were living with HIV. So, we want to when someone's infected with HIV, we want to catch that right away, because they're going to have better health outcomes if we start them on treatment right away. And it's a shame when someone, that doesn't know about their HIV status until they end up in the hospital with some kind of, really rare pneumonia or cancer or some other, end stage health issue related to HIV.
Yeah, no, that absolutely makes sense. And I think that that's one of the biggest pieces of stigma that at least I see out there in Eastern Oregon and everywhere, right? Is that, oh, it's you should only get tested if you fit into these high risk categories, right? But
Mm-hmm.
I mean, I like to tell people, if you even have ever had a history of any sexually transmitted infection, you're at risk
Mm-hmm. Mm-hmm.
of HIV as well. And I think that that's really important for people to understand. HIV doesn't identify people, right? It like you've said, it's all about behavior.
Yeah.
And if I'm someone that wants to be HIV tested, and um, how do I talk to my provider about that?
That's a really good question. I wouldn't assume that your provider is going to offer you an HIV test. Um, I think partly because medical visits are so short, and
Yeah,
providers are really overwhelmed, and there's so much to do, and it's really easy to just kind of put it aside and say, we'll do that later. So I think it's important for people to actually ask for HIV screening, and and try to raise the issue with their providers. Providers also don't like to talk about sex with their patients or drug use, things like that. So, you don't necessarily have to, if you don't want to talk to your provider about those details, you don't have to, but at least just saying, I've never had an HIV test, or I haven't had an HIV test in a while. Can you just please add it to my labs? I think any provider is going to do that. And if you have a provider that reacts in a sort of a way where they're like, but I don't think that you have risk, or why would you want to do that? Maybe you should find a new provider, or you can buy home kits, at the pharmacy, and test at home if you prefer to do that way and you have the
yeah.
money for it. So.
Wonderful. Yeah. And just to add a little bit more about those HIV testing resources, there are a lot out there. At EOCIL, we do HIV testing very quick and easy. It takes about 20 minutes to get your results. The whole session is only about 30 minutes. And there's no blood involved. That's my favorite part, right? We don't have to prick
Mhm.
any fingers or any needles. That it's just a quick saliva test. So there's community, and EOCIL isn't the only community resource that people have, right? There are, depending on your area, there are other health departments that offer free HIV testing or low cost HIV
Mhm.
testing. TakeMeHome.org in Oregon also allows you to do all STI testing at home. It gets sent directly to
Mm-hmm.
your house. You do the swabs, you do all the tests necessary, and you get your results online. That's always an option for people who don't have that rapport with their PCP as well.
Mm-hmm.
And kind of going off that last question, how can I begin the HIV conversation with my partner? How can I ask about their status? How can I share my status?
Mm-hmm. Yeah, I think that's another good question, and also you can't expect that your partner is going to bring it up. Even if they have HIV
Hmm.
infection, they,
Yeah.
that might not be something that they want to disclose right away. So I always counsel people, you can sometimes it's easier to start the conversation if you talk about yourself, rather than just going and asking a partner questions right away. So I encourage people to say, I just want to let you know that I had an HIV screening 3 months ago and it was negative. Or I want you to know that I'm living with HIV and I take my medication and my viral load has been undetectable for, you know, 5 years or whatever, So sometimes like that kind of personal disclosure, if you feel comfortable with it, can be a way for someone else to feel safe enough to disclose that information. Um, and sometimes people haven't even thought about it. They might
Yeah.
not have ever tested. A lot of people, especially I find kind of folks that are younger than me who didn't grow up in a world where HIV was so scary. Sometimes it's just not something that they thought very much about.
Absolutely. I can definitely attest to that, right? I grew up in like the late 2010, right?
Hmm.
And received my education about HIV there. And you do kind of have it was a lot of it was fear-based. I think
Hmm.
still, right? But um it's an important conversation to have. And there's many apps that out there too, right? We see like Grindr,
Hmm.
Sniffies. A
Hmm.
lot of times they have a place where you can disclose status or begin that conversation. Do you think that's
Hmm.
something that helps people, or in a way, do you think that it makes it harder?
Well, I think it's like on the apps, I think that it's probably helpful. You just kind of put it out there. It's just like the same as your age or whatever you're looking for on those apps. I do worry sometimes that it might kind of it might having those things on the apps might kind of like encourage stigma a little bit. That they might you know people might be selecting their sex partners based upon their HIV status, which is, we know from the science now that you don't have to do that. And it's also, I think sometimes it, if someone identifies as HIV negative on an app, it can give like a false sense of safety.
Yeah.
And
Yeah.
it's folks who don't know that they're infected and are not on treatment are the source of most of the new infections. So, just because someone had a negative HIV test 6 months ago doesn't mean that their status is negative right now. So you do have to kind of ask more than just the have you been tested negative?
Absolutely. I think that's a very, very important message. I I when I also think that they can create more stigma through those different
Mm-hmm.
things. So it's again that having that conversation with your sexual partners is really important. Even if
Mm-hmm.
their status is negative, like you said, that could have been 6 months ago, and today could be
Mm-hmm.
different. Uh,
Mm-hmm.
Wonderful. And then this leads us kind of into a little conversation about prevention and testing. What are the most effective methods today of preventing HIV transmission?
So we're lucky today we have a whole menu of options. It's not just condoms. You can still use condoms, but we have things that are actually more effective right now. So we have a lot of what we call biomedical HIV prevention strategies. So that's using medications to prevent HIV. And like like I said before, so treating people with HIV is one strong piece of HIV prevention. So getting people into that undetectable equals untransmittable place. And then we also have PrEP, or pre-exposure prevention, where people take a medication either on a daily basis or every so often to uh, prevent the acquiring HIV. So those would be people that don't have HIV that are taking a medication to prevent HIV. And then we also have something called post-exposure prevention. So if you were to be, say, last night you went out and had a few drinks and you had sex with someone and you didn't really have a conversation with them about their HIV status and you didn't use a condom, and you wake up the next morning, you can take medication for a month, as long as you start the medication within 72 hours or 3 days. And that can help prevent any sort of HIV that might have been transmitted, prevent it from becoming a full infection. And then I just think there's the things that are also kind of they're the more sort of structural sort of HIV prevention pieces. So people are less likely to get HIV if they have housing, if they have a supportive community around them, if they have their mental health treated, if they have access to clean injection equipment, if they, are treated for whatever substances that they're using, all of those kinds of things that contribute to HIV risk.
So you talked about both PrEP and PEP.
Mhm.
So for our listeners, would PrEP be more like birth control, where you take it daily? Is that an accurate
Yeah,
compare?
I would say that's an accurate way to describe it. It's like birth control. Most people take PrEP as a pill on a daily basis. There's also options to take it as an injection every other month. And then some people use it only during times when they have risk for HIV. So they might not be taking it every day, but maybe they use it every month or every other month. So yeah, I kind of think of that as birth control. And then you can kind of think of PEP, or post-exposure prevention, as almost kind of like the morning after pill,
Hmm.
except that you take the morning after pill for a month
Yeah,
afterwards.
yeah. It's a little different in that sense.
Hmm.
Okay, I think that's wonderful. If I'm someone who is interested in PrEP, right? We just spoke about how who's at risk for HIV and who should be testing. How can I talk to my provider about PrEP? How can I begin that conversation? I know there's been
Hmm.
um, uh, people that go into their providers and maybe want to start that conversation, ask their provider about PrEP, and their provider goes, "Well, I don't know anything about it," or you're not gay, you don't need PrEP.
Hmm.
And that sounds crazy, but I know that those are things that sometimes happen to patients.
Yeah, definitely. Yeah, I think there's a few barriers to providers providing PrEP. One is that they just don't understand it, because PrEP does involve some HIV medications, and a lot of providers kind of feel like, oh, that's infectious disease specialists, that's their domain. So they feel uncomfortable prescribing those medications, or feel like it's going to be a big burden to do the lab monitoring and stuff like that. And then there's also that, yeah, like what you were talking about, Richard, where the provider doesn't think that their patient's at risk and needs PrEP. So I offer PrEP to anyone who wants it, even if they don't describe their risk, because people aren't describe their risk as very high, because people don't always tell you what kind of risk they truly have. So yeah, so I think it's just one of those things to ask your provider for it, and if your provider doesn't have experience with PrEP before, they may want to refer you to a PrEP program, where you get that dedicated healthcare. They may be willing to learn on their own, and there's lots of resources for providers to learn how to do PrEP, and it's pretty easy to manage PrEP once you've kind of gotten into the rhythm of it. And if a provider is not if a provider is not going to give you PrEP, or if they don't react to that request in a way that is affirmative, like, congratulating you for making a decision to take care of your health, they're probably not the right provider for you. So
Yeah, I think that for a lot of people who want to begin that conversation, it can be discouraging. And
mhm,
I think I'd like to just reiterate that to not be discouraged, right? To
mhm,
seek other options. There are other options like you said, teleprep services or different
mhm,
prep programs. And I know right now you're running a study with OHSU on injectable prep. Can you
mhm.
tell us a little bit more about that? Because injectable prep is, like you said, another option for prep services.
Yeah, so what injectable PrEP is awesome. It's a shot every other month, so it's 6 shots a year to be protected from HIV, and it's actually in the studies, it's more effective than taking pills, probably because it's easier to get a shot every 2 months than to take a pill every day. Taking
Ad
pills is hard.
Adherence, right?
Yeah, yeah.
Yeah.
So, but what we're doing, so there's a lot of challenges to getting long-acting injectable PrEP to people. And part of that is because it has to be given by a healthcare provider. So you can't just pick it up at the pharmacy and give it to yourself at home. So what we're doing with our tele-PrEP program is that we're meeting people for a first PrEP visit. And if they want to be on long-acting PrEP, we're referring them to the OHSU home infusion pharmacy. And the home infusion pharmacy actually delivers medications to people in their homes. So someone can have a nurse come to their home every other month and give the medication, and then also they can draw labs, and then also just kind of check in about how things are going with the medication. So it's a awesome service. The other great thing is that the home infusion pharmacy covers a large territory in Oregon. So it's possible that if you're, say, if you're in Pendleton, or if you're down in Medford, or somewhere on the coast, you probably won't have access to injectable PrEP, at least at this point in time. So if you have a telemedicine visit and then have a nurse travel to you, that's a way that you can get access. And so our study is basically, it's a demonstration project. So we are looking to see if this model is actually successful, with the idea that if it is, we could share it with other parts of the country. And we're also interested in the experience of individuals who are receiving the PrEP services. So we have some questionnaires during the study asking people how they like the service. So the study is not a study of the PrEP medicine. It's a study of the model, the system that we're using to try to deliver it to people.
Wonderful. And how can people get connected to that study?
Sure. So we have a toll-free number, and that number is, sorry, my dog is hacking on something. I don't know if you can hear that.
No, it's okay.
So we have a toll-free number, which is 833-770-1400. And we also have an email address, which is prepstudy, all one word, at ohsu.edu. We do have a website, but it's kind of a cumbersome address. The URL is very long, so I'm not going to read that. But if you did a search for OHSU and PrEP study in a browser, it probably would pop up.
That's wonderful. I think that I think as well as HIV, PrEP also carries a lot of stigma. And I think that
Mhm.
these different models to deliver PrEP to different service areas, I think is going to help us in our prevention against HIV.
Mhm.
Um, are there, I talked a little bit about how PrEP also carries a lot of stigma.
Mhm.
What would you say again to a provider who who carries that stigma.
Mm-hmm. Yeah, so I always start by saying that PrEP. So I think that there's this thought that somehow if you're using PrEP, you're, quote unquote, high risk, that you're doing things that are risky and that there's something irresponsible about that. And I try to get providers to think differently. For one thing, you don't have to be, having sex with everyone in the world in order to get HIV. All it takes is one partner um, to spread HIV to you. So, I always kind of start with that, and then I also um, talk a lot about, this idea of kind of it's with your HIV risk, it's not the stroke you're swimming, it's the pool you're swimming in. So a lot of times risk for any kind of infection has to do with how much of that infection is out in the community. We saw that with the COVID pandemic, the more COVID cases
Mhm.
there are, the
Yeah.
more at risk that you're going to be. So I talk about that. And then I also tell providers, we need to be congratulating people for wanting to do something positive for their health. So taking PrEP is like like getting your blood pressure checked, or taking your diabetes medication, or, taking medications to lower cholesterol, things like that. It should be seen as a positive thing to reduce someone's risk of disease and not a marker that somehow they are, a risky person who is behaving irresponsibly.
Yeah, I think you hit it right on the nail. Do you know of any resources that providers can use to do their own research on HIV or HIV prevention and PrEP services?
Oh, definitely. So the every part of the country has an AIDS education and training center. So in Oregon, we have the Oregon AIDS Education and Training Center. These are federally and state funded organizations whose job it is to teach providers and other types of service providers um, in the HIV community on how to do things like PrEP, HIV screening, STI testing and screening, things like that. So that's always a resource, reaching out to those agencies. There's also, if you go to the CDC, the Centers for Disease Control website, they have great resources for providers on how to prescribe PrEP, including just some like basic one sheets, of like, these are the labs you order, this is how often you do the monitoring. And then also there's something called the Clinicians Consultation Center, which is at the University of California, San Francisco. And they have warm lines. They have a warm line for PrEP. So you can call and leave a message, and then a PrEP expert provider will call you back if you have questions or need some coaching. And then they also have a hotline for PEP, the post-exposure prophylaxis, where you can reach someone pretty much right away and with questions, and that's available to all providers. And their address is ccc.ucsf.edu.
Wonderful. Um, we spoke a little bit about, the
Actually, hey, oops, sorry, it is.
we can go back. Yeah.
Yeah, I gave you the wrong, let's see here. Just want to give the correct address for that. I'm sorry, so the web address for the National Clinician Consultation Center is NCCC, so 3cs.ucsf.edu.
Wonderful. Okay. Hope people, I think it's just important to let people know that there are resources both for people interested in PrEP.
Mm-hmm.
In at least in Oregon, we have people that can help navigate all these different PrEP options, that can help navigate finding a provider, finding a pharmacy that you feel comfortable, that you feel safe with. I know that
Mm-hmm.
because PrEP carries a lot of stigma, especially in rural areas, right?
Mm-hmm. Mm-hmm.
Even just going to a pharmacist can be, an exposure to someone that
Yeah.
pharmacist could be someone at your church. That pharmacist could be, your mom's friend. And so it's important to know that there are other options, that there's other options for privacy and PrEP. Thankfully, today is available for the majority of folks.
Yeah.
Um, Now let's talk about treatment advances. What does treatment for HIV look like today?
So I think, when I see someone who's newly diagnosed with HIV, I usually tell them like it's never a good time to have HIV, but it's probably the best time to have HIV in terms of the treatment options that are available.
Yeah.
So we have a lot of treatment options, and um, these are medications that are really, really potent and effective at suppressing the HIV virus and getting it down to undetectable. So I can pretty much guarantee that if I prescribe a medication for someone, we're going to be able to suppress the HIV viral load and get it down to undetectable. And the other great thing is that the medications have much fewer side effects than they used to in the past, and there's far fewer pills. So most of my patients are on like a one pill once a day HIV treatment, which is awesome because back in the past, people would be taking tons of pills, several times a day, and they would have horrible side effects. People would have like horrible diarrhea, anemia. They would have nerve damage from the medications. They would have, fat move from one part of their body to another. It was really, really toxic treatments. And now our treatments are very safe and very effective. So, and we also have long-acting treatments now as well. So just like we have long-acting PrEP, there's a few options of medications where you don't have to take them every day, which is
Wow,
awesome.
that is awesome. I mean, you look back even just 10 years,
Hmm.
that was very different. And I think it's amazing the advancements that we're seeing today in treatment. For people who may be hesitant or there may be challenges. One, what are those challenges for people seeking treatment that you've seen?
Hmm. Oh my gosh. So there's a lot of, getting HIV care can be really challenging for a lot of people. I think the number one challenge um, goes back to testing, is that people don't know that they need it. They don't know that they have an HIV infection.
Yeah.
I think another big challenge is that, um, healthcare is not the number one priority for a lot of people, especially if say you're houseless, or you're a mom with 3 or 4 young kids, or you are struggling with mental health issues or whatever it is, or you have a really, really busy, demanding job. Healthcare might not be priority number one. So that can be a real barrier for people getting into HIV care and keeping up with it. Um, and then, then there's also the stigma around it and the fears about, what will the treatment do to me? What will it mean if people see me walking into a clinic where people with HIV are known to be treated? Or can I even get to the clinic because, I don't have a car and I have transportation issues, or
Hmm.
um, those types of barriers, or people are also very, the medications used to treat HIV are extremely expensive. And a lot of times, patients aren't paying, $3,000 a month for their HIV meds. Often it's some kind of patient assistance program or the federal government. But if people don't know that, people think like, I can't afford HIV care. I can't afford the medical visits, and I can't afford, to pay for labs. So, if someone's underinsured or uninsured, that can be a real barrier.
Yeah. And are there ways to help navigate those barriers?
Oh yeah. So in the state of Oregon, there are HIV service organizations. So EOCIL is one of them.
Yes.
Also, HIV Alliance covers a large portion of the state, and then in the Portland metro area, it's Cascade AIDS Project, or I'm sorry, it's not Cascade AIDS Project, it's OHSU Partnership Project.
Mhm.
So these are organizations that have case managers. So people
Yeah.
living with HIV can access a case manager, and that case manager can help you find providers. They can help you get on the right kind of insurance. They can help you access what's called Care Assist, which is a federally funded program in Oregon that pays for HIV treatment for people that can't afford it themselves. They can also often help folks navigate, all of the other barriers that get in the way of HIV care. So access to substance use treatment, access to transportation, referrals for housing, although that's really hard now just because we have a housing shortage in this
Yeah.
state. So they can help provide some of the other support services that are needed for someone to be able to take that one pill once a day, you know.
Yeah, absolutely. Like you said, EOCIL does offer case management services, and I think a lot of difficulty is that stigma that you talked
Mhm.
about going into somewhere that, oh, they provide HIV services. I think the wonderful thing about EOCIL is that we offer a multitude of services, right? Not just
Mhm.
HIV services. We offer harm reduction services. We offer independent living services, 2S LGBTQIA services. So there's it's not just HIV services.
Yeah, yeah.
And again, you also talked about a little bit about, the side effects that we used to have with HIV treatment. That is no longer the case, but can you also talk about how treatment has improved the quality of life for individuals living with HIV today?
Of course, yeah. So now that we have treatments that aren't super toxic, someone who starts HIV treatment is expected to live, like a near normal lifespan, and be healthy during that lifespan. The treatments, once you're able to suppress that HIV infection in the body, that gives the body and its immune system, a break from trying to fight the HIV. And so people can regain their health. People often, when they start treatment, will gain some weight. And I tell people it's a good weight, because that means that your body is not being depleted by trying to fight this HIV infection.
Hmm.
Um, People are, I have patients who have strong immune systems, and, I don't think of them as being immunocompromised the way that, we used to. I think of them as having immune systems that are just like everyone else's, and having just sort of the average risk for other diseases that people without HIV have. So there's definitely um, huge improvements to quality of life that way. Just some other things, like because we have treatments, um, people can get pregnant and have kids if they want. People can, like we said, with undetectable equals untransmittable, people can have sex lives
Hmm.
without worrying about transmitting to their partners. So there's just huge benefits to the HIV treatments that we have right now.
That's again awesome to hear, and um, I think we're headed in a really good direction. Going
Mhm.
back to stigma though, stigma and discrimination, how do you think, and you talked a little bit about this, but if you could just say a little more about how stigma impacts those individuals living with HIV, and
Mhm.
what can be done to reduce it?
Yeah, I mean, unfortunately, so stigma can be, there's different types of stigma. So, there's the stigma that is like kind of like the blatant stigma, like for instance, say like a clinic refusing to see someone with an HIV diagnosis. Like that is blatant stigma, but most stigma is not like that.
Hmm.
Oftentimes stigma can be kind of an attitude about people living with HIV. And sometimes it's even
Yeah.
people living with HIV themselves that might have that attitude that somehow they are deserving of their disease, or that
Yeah.
they are, you know, for some reason, you know, that they feel like it's a poor mark upon them that they have HIV infection. Or it can be, you know, the healthcare system or the clinic or the provider, kind of like what we talked about before, that somehow someone, because of irresponsible behavior, has HIV.
Yeah.
You know, that can be stigma. Um, and so, you know, I think one of the things with stigma is we have to acknowledge that it exists, and we have to constantly be checking ourselves around it. And we need to constantly, as healthcare providers, at least, we need to be thinking about folks living with HIV as, you know, the way we would think about any patient. You know, there's no point in playing a blame game with people and their HIV statuses. And that also goes for, you know, like in the clinic setting, making sure that everyone in the clinic, not just the providers, treat folks living with HIV with a lot of respect, just as they would any other patient. And then, you know, in terms of kind of that internalized stigma that people have, I think things like undetectable equals untransmittable have been huge at reducing that kind of stigma, because people don't have to worry about their, you know, transmitting to other people and the risk that's involved with that. So, you know,
Yeah.
and yeah.
No, I think that you hit it right on the dot there, where it's not just the stigma about you know, the knowledge about PrEP, I mean about HIV and what people think of HIV, but also with providers, right?
Hmm.
Do you think that also affects people seeking services for HIV?
Oh, definitely. And I think it works both ways. So sometimes there's people that don't want to be seen in a clinic that serves a lot of people living with HIV, you know,
Um,
because they don't want to be linked to that. They're
yeah,
concerned if someone will see them. But then there's also people that, you know, directly seek out an HIV practice, because they know that the folks there are going to be dedicated to the infection, dedicated to treating the disease, and treat them with respect, and have the right attitudes, you know, making sure that people can live as full of lives as possible and still have sex and still have kids and, you know, do all of the things that they want to do.
yeah. I think again, bringing that people can live a really normal life today, and like you said, the life
Hmm.
expectancy is very similar to someone not living with HIV.
Hmm.
Uh, what can we do as a community, as people, to further reduce the stigma around HIV?
Yeah, that's a great question. I think it's, you know, just acknowledging that that stigma exists, that it still exists. I think normalizing a lot of the, especially a lot of the prevention efforts, you know, just normalizing that PrEP is available and some people benefit from it. Normalizing testing, that a test is something that you just get. It's not a marker of any sort of judgment.
Hmm.
You know, just making sure that we normalize things as much as possible. Um, that we acknowledge the uh, the message of undetectable equals untransmittable, that it's zero risk, and take that seriously. You know, I think those are all things that we as a community can really do to address a lot of the stigma that still exists around HIV.
Yeah, I think that's a wonderful message too. And do you see any common misconceptions about HIV that you encounter frequently with your patients or with
Oh yeah.
community providers?
Yeah, so I think, you know, probably the biggest misconception is that people still think that there's a death sentence, if you have an HIV diagnosis. So I still have patients who have a new diagnosis who think they're going to die very soon, and so part of my job is to clear up that misconception and say, no, if we get you on treatment, you will have a long, healthy life. I think there's misconceptions that people living with HIV can't or shouldn't have kids. And so that's another thing that when someone's new, it comes to my clinic and they have a new diagnosis, is I make sure that I check in about kind of what their family planning goals are and make sure that they know that they can still have a family living with HIV.
Mhm.
And then of course there's just still there's still this idea that somehow HIV is a punishment for for people that deserve it because of some kind of irresponsible behavior that they participated in. And so, I think that's a huge misconception, and that
Yeah.
only certain types of people are at risk. And um, that's just not how it is. We know
No,
better than that now.
absolutely. And it's important to dismantle those misconceptions to, again, to reduce that stigma as well. I think that a
Mm-hmm.
lot of these misconceptions are at the forefront of the stigma that a lot of people living with HIV face. Um, Now in terms of global perspective, do you know how HIV care differs in various parts of the world?
Yeah, so, and this is not my area of expertise, I have to say.
Yeah.
The epidemic in the US is what I know the most about.
Uh-huh.
But I do know that in different parts of the world, HIV care looks really different. Part of that is the treatments that are available. So the US tends to have, all of the newest treatments right away. And in other areas of the world, the first line treatments might be what we consider to be a little bit outdated.
Hmm.
But that's okay. They still successfully treat HIV. Then also in different parts of the world, the model of getting HIV care might be different. So just because, like, for instance, like in sub-Saharan Africa, like there's not as many doctors and nurses available. So you might have community health workers be much more involved in your HIV care. Um, so that can also be a way that it's different. Medications are cheaper also in other parts of the world. So
Wow.
unfortunately, we have in the United States are overly tolerant of sky high, medication
Absolutely. Yeah.
costs.
That's interesting, right? Because our access to treatment is very good in the United States, right?
Hmm.
And even throughout COVID in China with the lockdowns, I read a couple articles about how difficult it was for people to get their medication
Hmm.
during the lockdowns, where it was just so strictly about where people moved and how they moved. And it's easy to forget those things. And I imagine even in places with war, right? I
Hmm.
imagine the trouble that people are having today in Palestine, trying to access their medication, and it's always easy to forget those people when in those crises.
Hmm. Definitely.
Uh, and then I think we spoke a little bit about this, but when we talked about HIV treatment, but I think it's also important to talk about how HIV treatment isn't just medical. Right. I
Hmm.
think at EOCIL we look at it in order to get someone to viral suppression to undetectable. Multiple things need to be happening. Can you talk about a little bit about those things?
Yeah, it's really all of those other support systems that are so important. Taking a pill in some ways is the easiest part.
Yeah.
The harder part is, having a home where you can store the pills and have them
Yeah.
available to you and have them not get stolen.
Mhm.
having access to food if you need food in order to take your medication, having access to some kind of stable income so that you can prioritize your health, um, having a supportive community of people around you, and hopefully having some people who you really trust know your HIV status, whether they're friends or family or um, HIV service providers like a medical case manager or something like that.
Mhm.
People that can support you, make sure that you're taking your medications, make sure that you're prioritizing your health care, all of those types of things. So it's not just the pill. And then also just getting access to all of the other services that folks need to stay on top of their health in terms of access to substance use treatment. If you're actively using a substance, that can definitely make it harder to take a medication every day. Um, if you're struggling with mental health, which is pretty common in the HIV world, just because of all of the trauma that is often linked. Just getting an HIV diagnosis is a pretty traumatic experience for a lot of people. So, making sure that people have good mental health, so they feel like that their health is that they are worthwhile, and that their health is something that they need to take care of. So I think those are some of the things that are not just taking the pill that are required for being in HIV care.
Absolutely. I think, yeah, at EOCL, we try and support with, at times, either we have our food pantry, we
Mm-hmm.
have our harm reduction program. So we really take our HIV care and try and make it as holistic as possible, trying to do that reach around, and providing all the services that someone needs to keep healthy.
Mm-hmm.
Uh, and now, going into the future outlook of HIV, are there any promising developments on the horizon for someone living with HIV, and what forms of support are, I'm going to say that one again.
Okay.
Are there are there promising developments on the horizon in terms of HIV research or treatment?
Yeah, so I think the one thing that we're all waiting for is a cure. So there is
Um,
still work going on with a cure, and I don't know how quickly it's going to happen, but I think that the research is to a place where I think we can start envisioning a world where there's an HIV cure. I mean, we do know how to cure HIV. There have been people that have been cured
yeah,
through a bone marrow transplant.
yeah.
But unfortunately, that's like a 50-50 chance that the transplant will kill you. So that's not a safe or effective way to cure HIV.
And if
Um,
I'm correct, those people that were cured from H, very specific, right? They
mhm.
received the bone marrow transplant, but they were also living with leukemia, right? Or like
Yeah,
cancer.
yeah. So they received the bone marrow transplant because of cancer, a blood
Mhm.
cancer. And the type of transplant that they got was from someone who is essentially immune to HIV.
Yep, yep.
And so, yeah, so we know how to cure it. I mean, every so often I have a patient say, like, can you get me one of those bone marrow transplants? And I'm just
Yeah.
like, you don't want that. That's
No, yeah, because bone marrow transplants do carry a lot of different risks,
oh
but
yeah.
that's a
Yeah.
super interesting. I definitely like to
Yeah.
geek about this kind of stuff, like the cures that we've seen, and
Yeah. Yeah. But I'm hopeful that soon, and I don't know what soon means exactly, maybe the next 10 years, we will begin to be thinking of HIV more as the way that we think about cancer remission, that we'll have treatments that can sort of maybe we can't uh, cause someone to get to a point where they have a negative HIV test, or that we can guarantee that there's not a single piece of HIV virus in their body, but we'll know that it's locked away and it's not harming them, and they're not infectious to other people, and that they can go ahead and live their lives without taking pills all the time. So I think I think that's, one of the things in the future. And to me, that would be a cure, if we're
Yeah,
able to
yeah,
get there.
absolutely. Is that kind of what you envision for the future of HIV care, right? Where people can live their lives not having to take a daily medication and seeing more like cancer, I think is what you said, where they're in remission.
Yeah, that's what my hope is. And right now in the HIV treatment world, it's all about longer acting treatment options. It's really
Mhm.
trying to address, how hard it is to take pills every day, with 100% adherence for the rest of your life.
Yeah.
And so if we can move towards, not having to take medication every so often, but still have successful treatment, I think that's going to be a huge benefit. And if we're able to, in some way, sort of, I mean, I know researchers are looking at it in different ways. Some of them are trying to sort of lock the HIV in the places in the body where it's kind of being stored, it's hibernating so that it doesn't
Mhm.
cause harm. Others are trying to like get all of the HIV, rounded up and kill all of it at the same
Yeah.
time. So, there's a lot of promising research happening. Unfortunately, I don't think it's nothing that's gonna like happen in the next 2 to 5 years or so.
No, no, definitely not. Is there any ways that someone wants to get involved with the research that's happening? Maybe not in Oregon, but how can people find that?
Yeah, so if you go to clinicaltrials.gov, you can search for different, clinical trials related to HIV, and there might be
Mhm.
something there that that you might be interested in. Um, Also just contacting, the HIV programs and some of the larger healthcare systems or academic healthcare centers in places that have a lot of uh, uh, or high HIV prevalence. So,
Mhm.
contacting like the University of Washington or UCSF, UCLA, um, you know, the East Coast universities, that kind of stuff.
Wonderful. That um kind of concluding our episode. I've had a wonderful time chatting with you. But can you
Thank
share
you.
a memorable or impactful patient story that the listeners can leave with?
Yeah, so I have to be careful about,
Yeah.
confidentiality.
Yeah, yeah, absolutely. Just like the main message of this. Right?
Yeah, I think so. I think some of the most impactful patient stories for me are the ones where someone comes to me with a new HIV diagnosis and they weren't aware that they were at risk, and maybe they don't have very much knowledge about HIV, and to see them move through different stages to where they realize that they have the opportunity to control the HIV and be healthy, and then move on to stages, where they're getting more and more involved in sort of like the HIV community work that has to be done. So maybe they're involved with support groups or they become a peer mentor or something like
Good.
that. It's exciting to see people move from like that place where they don't know anything about HIV and they're scared to a place where they're really empowered and they're helping other people. I'm also always impressed by um, the the moms that I work
Mhm.
with who
Yeah.
like they started having kids after their HIV diagnosis and seeing their kids grow up and get older. Like those are always inspiring moments for me because that wasn't how the HIV epidemic was in the early days. So
Yeah,
it seems like there's
absolutely.
a lot of hope now. And it's just awesome to see people sort of taking charge of their lives. I think one thing that's kind of interesting about chronic illness is that not everyone, but there are people who, they don't really take care of themselves until something happens, they get
Mhm.
diabetes or they get HIV or they have heart
Yeah,
failure or something like that. And it can be a real motivator, and they actually end up sort of healthier than they were before their diagnosis, because
absolutely.
it's kind of this like wake up call that's really motivating. So
Absolutely. I
it's
think
always
that
inspiring.
that's definitely really inspiring, impactful to um see people's journey, right?
Mm-hmm.
From the moment of their diagnosis to living a very healthy life. And it's for me, it's wonderful to hear just like the stories about the mothers who have
Mm-hmm.
gone on and still created the family that they wanted to create. And
Mm-hmm.
it just goes more again to show where we're at today
Mm-hmm.
with HIV, which is not where we
Mm-hmm.
were at 30 years ago.
Yes, exactly.
Well, that's it for today's episode of the Sexual Health Spotlight. Please join us next month on a new episode of the Sexual Health Spotlight. And again, thank you, Chris, for joining me today.
Yeah, thanks so much for having me. I've had fun. This is it's great to be able to talk about these things. So
Yeah,
thank you so
absolutely.
much.
Live your life within the
And as we close out today's episode, folks, I would like to thank you for tuning in and listening, and I would like to thank Richard and Chris Fox for the episode they provided. If you have any questions about any of the material covered throughout this episode, I encourage you all to check us out online at www.eocil.org or interact with us on any one of our various social media platforms. We also have 4 office locations throughout Eastern Oregon that we encourage you all to drop in and visit, whether that be in the Dalles, Pendleton, LeGrand, or Ontario. With that, this has been a podcast by Eastern Oregon Center for Independent Living.
we get lost in the crowd, it's getting thicker.